So the first question is there a difference in a small fiber neuropathy that causes pain versus a small fiber neuropathy that causes autonomic nervous system disorders or POTS? And is in terms of testing and treatment. So the question is that is there any, some patients may have a small fiber polyneuropathy that predominantly affects the sensory nerves, and they don't have the autonomic dysfunction. And on the other hand, there are some patients that have damage to those types of small nerve fibers that control the autonomic nervous system, while they don't have a lot of sensory symptoms. And these have been reported in multiple papers. So patients can have both. Most of them do, but they could have just one of these. The workup is the same for both group of people. In terms of testing, in patients who specifically have autonomic dysfunction, they might have normal skin biopsy, but they could have abnormal autonomic function testing, and vice versa. Patients with predominantly sensory problems, they might have normal autonomic function testing, while the skin biopsy could be abnormal. The next question is that what approximate percent of POTS patients with a small fiber neuropathy improve with IVIG treatment or intravenous immunoglobulin? I don't know. I don't think anybody has an answer to this because this has not been specifically published and studied. People use it. I use it in some of my POTS patients, and I see benefit again in some of them. But I don't know what will be the percentage of that. It needs a study with a large number of patients. Next question is that how accurate is the punch biopsy on detecting small fiber neuropathy? And continue with one neurologist told me that different people have different number of nerve fibers, so it may be hard to determine on a skin biopsy if they have small fiber neuropathy or not. So the first part of the question, it's, there are different reports. It is pretty accurate, up to 70 to 80%. Some reports up to 90% sensitive in detecting patients with peripheral small fiber neuropathy. Some authors believe that if patient has a normal skin biopsy, does not have a small fiber neuropathy. And I'm not sure about that. I have a lot of patients with typical symptoms and normal skin biopsy, but they still could have a small fiber neuropathy because the function of the nerves might be affected, not the numbers. And when we do a skin biopsy, we compare the numbers with the normal controls based on the gender and sex, and that's why we can say if they have lost the numbers or not. And sometimes they can start with a number. I give you an example of 900, thank you, and they drop the numbers. When we do the skin biopsy, the number is 500. So compared to their first number, so they have dropped the number of the nerve fibers, but still 500 is within the normal range. So there are a lot of ifs about this. So I can say skin biopsy in patients with typical symptoms, if it's normal, it cannot really rule out a small fiber neuropathy. And the next question is that Charmaine told me that they heard that fibromyalgia has its own code in new ICD-10. At the same time, it has been reported that AMA chairman, Dr. Kimball, said while many doctors claim that fibromyalgia is that is a real disorder, after decades of a study, we have decided to remove it from the official list of medical diagnoses, as research has proven that it does not actually exist. I disagree with this statement, as I mentioned to you. So some patients can have objective finding of a small fiber neuropathy or other diseases, but a lot of patients is still, we cannot find any other explanation. So fibromyalgia still is a valid label for a collection of symptoms. And I think it's very premature to remove it from the ICD-10. I don't think it's going to happen because I'm sure a lot of physicians agree with me. So the next question. So there is a, I'm interested to know if you consider radio frequency exposure as a risk factor for, I'm not sure, the neuropathy or fibromyalgia, or if it works in the area of treating EHS or electromagnetic hypersensitivity syndrome. So this, I'm not sure, I don't think there's much data on that. So initially it was brought up because the Russians reported in 1970s that a lot of their Navy personnel, they developed chronic fatigue and non-specific symptoms, and they have been sitting with the radio all the time. And later it was reported by, I think it was Sweden. So there are a lot of reports on that, but we actually don't know if there are other environmental factors are involved, or it's just the waves. It's really hard to say if they affect our life or not, the computers, the cell phones. So I don't have the data on that, and I don't know, but I don't consider it because I cannot measure it. Okay, now we get to the written part. So about the list of the blood works, they're asking if it's in the website or not. I can give Charmaine, I'm not sure if we can do that or not, a copy of that list of the blood works, and you can put it on your website so everybody can use. Okay, the question is where in the body you do the skin biopsy. So it depends that which lab you use. In Mass General, we have normative data for ankle, the slide I showed you, 10 centimeter above the ankle. I can just show it again. So this is the area of the biopsy. But the other area that can be biopsied is on the thigh, higher up, so that we can measure the number of the nerves in the upper thigh. In patients that I told you that they present with length-dependent neuropathy, they may drop the number at the ankle, and they may have normal number at the thigh. But you should know where the biopsy is going to go. Some labs have normative data for arms, and some labs don't. So we can also do the biopsy of the arm, but there are some specific labs that they can just analyze those samples. Sometimes patients have unilateral symptoms, one arm or one leg. So what we do the biopsy from both sides and send it to the lab, and they compare the number of the nerves on both sides. That's the other way of useful. It can be in any part of the body, not head and neck area, but we can do it from almost everywhere else. And it's about treatment of small fiber neuropathy. I went over the medications. I show you again. So if we can find the cause, we treat the cause. If we cannot find the cause, or we cannot treat the cause, we treat the symptoms. And these are the typical medications we use to treat the symptoms. And sometimes we use immunomodulatory agents such as IVIG, steroids, or other immunosuppressive agents. The next question is that is Mass General willing to do a skin biopsy, and if it's covered by insurance or not? It is covered by insurance. There is a process, so patients should have at least one nerve conduction study that doesn't show neuropathy in large nerve fibers, and then the insurance will cover that. So this is the process for that, and Mass General does that. And the website I showed you, you can find the requisition forms. This website, neuropathycommons.org. So the next question is that they asked me to tell you a little bit more about treating the underlying causes of the small fiber neuropathy. Go back to this slide. So diabetes and borderline diabetes could be one of the causes, and simply treating that can help with small fiber neuropathy if that's the cause. So what I usually do 2-hour glucose tolerance test for most of the patients. So that's a sensitive test to pick up diabetes. I diagnose a lot of patients with just normal fasting sugar, but abnormal 2-hour testing. And they had full-fledged diabetes or borderline, and they were put on treatment. Thyroid dysfunction, so treating the thyroid disease. These autoimmune diseases have a lot of treatments available. So a lot of immunosuppressive treatments for all these autoimmunes. If they have vitamin deficiencies, you just replete the vitamins. Also, patients should be careful not to take too much of vitamin B6. There have been a lot of studies that how much vitamin B6 is safe. Some researchers started taking vitamin B6 themselves in gigantic doses, and they did the skin biopsies and see what dose is really safe. A lot of them develop neuropathy, and sometimes this is irreversible. So right now, the recommendation is that not to take more than 50 milligram of vitamin B6 daily. Above 50, there are some evidence that it could be toxic. Sometimes people prescribe it for carpal tunnel syndrome or other conditions, but people should be careful not to take more than that amount. So the other thing, celiac disease, a lot of patients have it and don't know. They don't have GI symptoms, but they may present with neuropathy. Going on gluten-free diet helps. Alcohol, so stopping alcohol may not reverse the neuropathy, but it can prevent the progression. And if it's an infection, treating the infection may help. I had a question asking about chronic Lyme. So it's a big controversy if it really exists or not. There was a study several years ago. They infected monkeys and treated them with conventional antibiotics, IV ceftriaxone and also doxycycline. And they sacrificed these animals, and they still were able to find the evidence of active Lyme in their organs. There were a lot of questions about that study, but that was, to my knowledge, it was the only study that said chronic Lyme may exist, but I really don't know. There's a lot of controversy on that. And if it's caused by a medication, so sometimes patients get better after stopping the medications. In chemotherapy, a lot of my patients that I have seen got better, maybe not back to normal. So they always had some degree of neuropathy. Paraproteinemias have their own treatments based on the syndrome that I told you. Amyloidosis, there are treatments available. One of them is being FDA approved. And if it's related to cancer, just treat the underlying cancer, may help. Yeah, I mentioned about the vitamin B6. The next question is that how much B6 is available. Is toxic, which I told you 50 milligram is the number. I'm not aware of any medication or diet that can help to remyelinate the nerve fibers. So first of all, small nerve fibers, they don't have myelin, or they have just a little bit of that. So myelin is for larger nerves, and that's a different condition. There is no diet or medication that help for the myelin to regenerate, but the treatments we use, for instance, there is a type of large fiber neuropathy, it's called CIDP. We use IVIG or steroids, and that prevents the immune attack to the nerves, and myelin can regenerate. But that does not apply to a small fiber neuropathy because these nerves don't have much myelin. So the question is about which antibiotics can cause a small nerve fiber damage. So I go back to this slide. Chemotherapy, some of them, so the platinum family, cisplatin, carboplatin are the major ones. Taxol is the other one that can cause neuropathy, and some other ones. Certain antibiotics, so nitrofurantoin, that is used for UTI, the prolonged use of that medication can cause neuropathy. Fluoroquinolones, like Cipro, there are some reports, and I have seen some patients, but some studies were negative, so it's unclear if they cause neuropathy or not. But I don't recommend to take Cipro if you have been diagnosed with neuropathy, or don't take it at least more than 5 to 7 days. The chronic use of these antibiotics can be toxic, and some anti-HIV medications are also neurotoxic. Cold, headaches, and tinnitus can be caused by a small fiber neuropathy. Chronic headache is a common symptom of patients with dysautonomia. That could be relevant. And tinnitus, I have seen a lot of patients with tinnitus, and that could be because of their drop in their blood pressure or autonomic nervous system. The question is, possibly it could, but other reasons should be first evaluated and excluded. in cases where the cause is unknown, do you suspect a preventive, so this neuropathy is caused by Lyme or other infections. So Lyme, I usually test that. If it's negative, I consider that patient doesn't have Lyme. I know again about the controversy of seronegative Lyme, but I don't personally believe in that. It could be present, but I don't put patients on treatment for Lyme if their test is negative. I look for other causes and I treat them. The same algorithm I told you, if I cannot find the cause and if it's severe, affecting their life and none of the symptomatic treatments help, we can use immunomodulatory agents. Okay, the question is that why patients with a small fiber neuropathy that have lost the nerves, the skin is more sensitive. Okay, this is that I've been asked by all neuropathy patients that if my nerves, if I'm losing nerves, why I still have pain, or if I have numbness and I don't feel a lot of things, how come I still have a lot of pain? And that's because, first of all, we have different nerve fibers, and so they have different functions. So when patients have neuropathy, they may lose some of the types of nerves, and still the rest of them are there. Overall, they have damage to all the nerve fibers, and based on which nerve fiber is more damaged, they may have symptoms. Although the number of the nerves are low, but remaining nerves are really sensitive because they're damaged and they can cause a lot of pain. That's why patients have numbness and pain. There is also a theory of central sensitization in addition to that these patients, because have chronic problem, there might be some central component to that. So I'm not sure if this question is to ask how is my memory. So what is the diagnostic code for fibromyalgia, ICD-9? I don't know. I don't know. We have electronic medical record, so when I put it, it will just generate that. I don't memorize these usually. You can look online. I'm sure there are a lot of websites. So the question is, was there a statistically significant, a large number of patients with a small fiber polyneuropathy compared to follow-up studies? I'm not sure what this means. Yes?
Okay. You mentioned studies in Italy and Spain or something.
Right.
It seemed like the numbers were lower.
Yeah, I told you the number of the patients. So all the results were statistically significant. So I have the numbers here for you. So this study is on 20 patients. This study is on 46.
Is it like 33% there? I thought Dr. Oakland was 60 or 70%.
It was in children. The first paper she published in children had 59% abnormalities. And so all of them are statistically significant. If you like, I can put also these 4 papers, if it's possible, on the website, and you can see all the details about that. Okay, all right, sure. So the next question is that, are you familiar with the MTHFR gene mutation and its effect on methylation pathways in the body, and if it can cause a small fiber neuropathy or not? I don't think it does. We don't check that. And to my knowledge, there have been no reports on that MTHFR can cause neuropathy. This is up to my knowledge, and because I work with a lot of people on neuropathy, I have never heard that in any of the conferences, so I don't think it does. But if there is any reference that you want to specifically specify, I can look it up. So the question, are you seeing preload failure with a small fiber polyneuropathy? So this preload, you mean the heart preload, or yes?
Vascular and heart.
So if you can you clarify what you mean by that?
Yes, I have a diagnosis by Dr. Oaklander of SPFN, and I failed the tilt table test. At the same time, I was sent to a pulmonary specialist because I'm exercise intolerant. And I had a special test. She said it's only given 2 places in the world. A cardiovascular stress test with a catheter in my wrist and my neck.
Right.
And the diagnosis was clearly preload failure. I got a second opinion. It sounds, the treatment for it, with the exception of the exercise, sounds so much like the treatment for
POTS.
the OI. As a matter of fact, I am wearing my compression fancy stockings right now. Are you, and the Dr. Sistrom at the Brigham, who diagnosed the preload failure, seems to be getting a lot more CFS and fibro patients, and he feels there's a strong connection. My other doctors find it very controversial, and I have good doctors.
Right. So what I think, to my understanding, preload failure means that the heart doesn't have enough blood to pump. So that's exactly what I explained to you that happens in the patients with dysautonomia.
Right.
Because, so first of all, they have up to 15% less, so they're always dehydrated. That's why they recommend up to 10 grams of salt per day to keep more, to increase the blood volume, and up to 2 liters of water daily. So they're always dehydrated because the kidneys cannot maintain the fluid for some reason, and they always have the preload.
I don't have it constantly. I have flares.
Right. And that's typical with this condition.
Is that typical?
It is typical.
Spring and fall,
Right.
seasonal changes.
Seasonal changes, heat.
Thank you, because my CFS doctor told me I was ridiculous and I should have allergy testing for the 15th time in my life. So.
No, my patients usually in certain times, so in POTS specifically in summer, so I see them more frequently. They call and they come in frequent. In winter, I don't see them. Sometimes they disappear for 6 months, and they feel better when it's cold. And definitely seasonal changes, temperature, humidity, they have something to do. There are a lot of unknown about that as just the temperature, or there are a lot of other factors we are not aware of. But I definitely see that in real life.
So you do see preload failure in OI?
Yes, almost all my POTS patients, they have preload failure.
Do you have them on an exercise program?
Yes, but the person that, the physical therapist, the person that does that should be aware of this condition. So,
I give a special program.
okay, and recommend bikes. And thank you so much. I need it for my patients. I don't have the answer to this question. So the question is, I showed in the slide, and I told you that a patient, an 18-year-old, had 875. So this is a slide, 675, and a patient with neuropathy had 155. The question is, what's the number for a 40-year-old male? I don't have that good of a memory to memorize all these numbers, but it's there are some graphs that it can just the numbers for different age, and I don't have it of. Yes. So the question is, I have some structural problems in my feet, and several podiatrists have refused to treat me with a usual surgical procedure when they find I have FMS, fibromyalgia. So some surgeons, they're scared of touching people with neuropathy because sometimes there will be a delayed healing, a prolonged pain. So one of the audience spoke with me about lip biopsy for diagnosis of Sjogren, and then she had 6 months or so pain in her mouth. So that's pretty common, and that's challenging. Sometimes happens that these people, after surgical or any procedure, they might have prolonged pain or discomfort in the area. I'm not aware of any podiatrist that knows how to treat patients with small fiber neuropathy, unfortunately. So the next question is a great question. Any correlation between a small fiber neuropathy and Ehlers-Danlos syndrome, or EDS? Yes, there are a lot of studies on that, and that's something that we consider in patients that have. So Ehlers-Danlos is a collagen disease. So they have lax joints, and they might have some vascular problems. But these people also can have a small fiber neuropathy. It is known correlation. I have a family of patients, a mother and two daughters, all have a small fiber neuropathy because of Ehlers-Danlos. So how to get an appointment? Enrolled in any studies? So it depends on which studies you're asking about. I'm not aware of any study that Dr. Oakland is recruiting patients for, if this is the question. But if you ask overall, the best website to learn about the studies is government website. So it's the, if I remember the website, clinicaltrials.gov. Thank you. So that's where you can find if any study in the nation is recruiting patients or not. That's the best place. But if you specifically ask about Mass General, I'm not aware of any study at the moment that she's recruiting patients. Yes, please.
That was my question. So I appreciate the work that you're doing. I think we all do. And I guess the question is, are there any other ways, because most general, you're so strong for patients, it's hard to get in. So are there any other doctors doing studies or other people that we can see? Because that's the bottom line.
Yeah, that's a big problem. The wait time for Dr. Oaklander is almost a year. And so I'm trying to start seeing some patients with her there so the clinic will be a little bit more accessible. At the moment, unfortunately, she's and Dr. Horowitz there and sometimes Dr. Cheng. These are the only people that see patients with this condition. Access is a big issue. I agree with you. So we're working on it. So, unfortunately, you don't find many neurologists that are interested in this field. That's a big problem. And a lot of people don't have enough understanding about this condition. And it's not only here, it's all over. It's the place I'm practicing. In New Hampshire, I found patients that have been undiagnosed for years. And I'm talking about 6-7 years, and they have had a lot of problems. So to answer your question, so we are trying to work on that to be more accessible in Mass General.
Thank you for coming today.
Oh, you're welcome. It was a great pleasure. So this is what I really like to spread the word, and I hope it was helpful for you. So the next question is, most doctors are not, I think, diagnosing thyroid/adrenal and or blood sugar for POTS. I think these are the things that definitely need to be checked, especially the adrenal gland. So the serum cortisol is very important because some people have adrenal problem and they may present with POTS. And blood sugar, as I told you, is one of the most common causes of a small fiber neuropathy, and I always check the patients for that, especially with more sensitive test, which is 2-hour glucose tolerance test. So how do we convince a doctor to view your studies or protocol and to order appropriate tests? Or, yeah, I don't know. So, yeah, we try to spread the word. And fortunately, more people are getting the knowledge about this condition. It is really underdiagnosed, and a lot of people don't believe in it. Some people think that these diseases are made-up diseases or they don't really exist. But after we have the objective findings, so they are being more convinced. So it's a process because it's a change in understanding, and change is always something difficult and takes time. So we are doing our best. So what is the definitive test for sarcoidosis? Is tissue diagnosis, because patients with sarcoidosis could have normal blood test, which is ACE or angiotensin converting enzyme. Sarcoidosis is an autoimmune disease. It predominantly involves lungs, so patients can present with respiratory symptoms, but it can also affect a lot of other organs like nerves and the central nervous system, even the brain. The best way of diagnosing is to get a sample of tissue, otherwise it will be very challenging. And I think that was the last question. Any other questions? Thank you.